Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Prescription opioids remain the most commonly misused prescription drug in the United States. For the past 2 decades, they are responsible for almost 300,000 deaths. The No Pain Act, signed into law in 2022, expands access to non-opioid pain management options. My Vizient colleagues, Carolyn Liptak, Pharmacy Executive Director in the Vizient Center for Pharmacy Practice Excellence, and Dr. Phil Mentler, Senior Consulting Director at Vizient, join me to clarify the No Pain Act. I'm Stacy Lauderdale, Associate Vice President in the Vizient Center for Pharmacy Practice Excellence and your program host. Phil and Carolyn, welcome back to the podcast.
Thanks for having us.
Yeah, thanks, Stacy.
Before we jump into discussing the No Pain Act, I want to share some sobering statistics from the Center for Disease Control and Prevention that's going to help frame our discussion. According to the CDC, in 2019, among persons aged 12 years and older, 9.7 million reported misuse of prescription opioids during the past year, and of those, 1.4 million met criteria for a past year prescription opioid use disorder. That's astounding. The CDC are saying that this number is declining since 2022, which is good news. But I think all of us would agree that we still have continuing work to do to address prescription opioid use problem more broadly, to continue to encourage multimodal strategies for pain management, which is the gold standard for pain management. I've been hearing about the No Pain Act for several years now. Carolyn, why don't you get us started and give us some background information about the law?
Back in October of 2018, the Support Act stated that the Secretary must review payments that are paid under the outpatient prospective payment system for opioids and evidence-based non-opioid alternatives for pain management, with a goal of ensuring that there are not financial incentives to use opioids instead of non-opioids. The Support Act stands for Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients and communities. In calendar year of 2020, the Centers for Medicare and Medicaid Services finalized a proposal to continue to unbundle typical bundled payments and pay separately for non-opioid pain management drugs at a rate of the typical ASP, average sales price, plus 6%. This applied to surgical supplies when furnished in the ambulatory care settings, and this went into effect in January of 2022. The No Pain Act was introduced in March of 2021. This bill amended the Social Security Act to combat the opioid crisis by promoting access to non-opioid treatments, specifically in the hospital outpatient setting. So then in December 2022, the Consolidated Appropriations Act was signed into law, and that required a payment for non-opioid treatment for pain relief furnished on or after January 1st of 2025, which is where we are now, but before January 1st of 2028. So this is a temporary payment. And it specifically states that payment for these products can't be packaged or bundled into a covered outpatient department service, and that additional separate payment must be made.
Thanks, Carolyn. And I must ask, because every act is an acronym, what does No Pain Act stand for?
No Pain Act stands for Non-Opioids Prevent Addiction in the Nation Act.
I knew it stood for something great. You told me a lot of wonderful information, Carolyn. What is new on January 1st, 2025 that they need to know?
Before January 1st, ambulatory surgical care centers received a separate payment for these products, but hospital outpatient departments did not. These costs were covered in the bundled payment for the procedure or the surgery. But on January 1st of this year, now hospital outpatient departments will receive a separate payment on top of the bundled payment. Keep in mind that only those drugs that qualify and meet the specific definition described in the Act. In order for these drugs to qualify, the drug must have a specific label indication approved by the FDA to reduce postoperative pain or produce post-surgical or regional analgesia without acting upon the body's opioid receptors. And for a medical device, it must be used to deliver such a therapy and must have demonstrated the ability to replace, reduce, or avoid intraoperative or postoperative opioid use or reduce the quantity of opioids prescribed. So not all non-opioid pain relief will qualify for this payment.
We're going to get into that specific point a little bit later. And I want to ask a clarifying question to ensure that our listeners are following along. What is the difference between a hospital outpatient department versus an ambulatory surgical center? Since that seems to be the difference of what happened on January 1st.
That outpatient ambulatory area is owned by the hospital, whereas an ambulatory surgery center is not necessarily owned by a hospital. It could be owned by a physician group or whatnot. There can be unique contracts, but it is not specifically owned by the hospital.
Thank you so much, Phil, for that clarification. That's an important point that on January 1st, it applies to the HOPDs. The ASCs already had separate reimbursement of these agents. A lot of our listeners hear a lot about Exparel and the No Pain Act. My question for you, Phil, are there any other drugs and or devices that are on the list other than Exparel?
Absolutely. There's Exparel. There's also Zinrelef, another long-acting bupivacaine. Xericol, which is an implant. You have two ophthalmics, Omidria and Dextenza. And then you have injectable ketorolac specifically. From a device perspective, we have the elastomeric pump, specifically the on-Q pump, elastomeric pump, and then the Amb-IT electric infusion pump, and then some cryo nerve block therapy, iovera system, and the Sprint peripheral nerve stimulator system.
Quite a few drugs and devices other than Exparel. But one of the interesting things that I heard is ketorolac injectable is on the list. But some of the things we oftentimes think about in terms of multimodal therapy, such as IV acetaminophen, generic local anesthetics, are not on the list. And it may not, in the overall scheme of things, be significant because these are generic drugs. They're not branded, presumably not that expensive. But what specifically prevents those agents from being added to the list?
If you think multimodal analgesia is the best approach as part of an early recovery program, why not ibuprofen? Why not naproxen? And the first thing to consider is the CMS selection of drugs and devices is not in itself an endorsement that those products should be used. It is just based on the letter of the law as it was written. That is what CMS approved. And then based on some commentary back and forth between different manufacturers, the list was slightly expanded. By no means does it mean that other non-opioid analgesics are not effective. They just didn't meet the letter of the law based on what the FDA was supposed to have in the labeling.
And Carolyn, what specifically does that FDA labeling have to say for it to be included?
In order for a drug to qualify, it must have a label indication approved by the FDA to specifically reduce postoperative pain or produce post-surgical or regional analgesia without acting upon the body's opioid receptors. That has to be in the label indication.
That might be why some of these ones we traditionally think of as non-opioids as a multimodal must not have that precise labeling.
Right. So if there's no mention of the postoperative or post-surgical use in the FDA-approved indications, it may not qualify.
Interesting. I want to reiterate what Phil said about this law should not be intended to assume that one is better than the other. That's a very important point. Ultimately, this law is about changes to reimbursement, not about therapeutic choices. Carolyn, walk me through reimbursement basics of the No Pain Act.
Basics of reimbursement apply regardless of the No Pain Act. Typically, hospital outpatient department and ambulatory surgical care reimbursement is covered in the outpatient prospective payment system. This is Medicare Part B. And high-cost medications that are given in these outpatient departments, like infusion centers or ORs or physician offices and clinics, they're covered by a separate payment. And this payment limit is typically set at the average sales price of the drug plus 6%. In surgical centers, typically all of the costs associated with that surgery or procedure are bundled into a separate payment. When CMS makes a separate payment, that payment is on top of the fees for whatever services are provided. It's a separate additional payment. When we say that CMS sets a payment limit and covers these medications, CMS actually pays 80% of that payment limit. The patient is actually responsible for 20%. There's a patient copay of 20%. High-cost medications are paid this way. When medications cost less than $140, they are absolutely bundled into the service provided. There is no extra payment. So that's probably where acetaminophen would fall. Not to say they couldn't make an exception, but acetaminophen is going to cost less than $140. Inside or outside this No Pain Act, it's not going to be separately payable. When the payments are bundled, there's not that additional copay for the patient. So when we think about reimbursement for these drugs, according to the No Pain Act in HOPDs and ASCs, the patients will now be responsible for 20% of the reimbursement. Now that these non-opioid treatments for pain relief are going to provide additional reimbursement for the hospital, they're also going to increase the patient's copay of 20% on top of the other fees. They may have a secondary insurance plan, or the hospital might have to write that off. Keep in mind when that you're looking at reimbursement, regardless of who the payer is, that reimbursement can change. And so what's covered today may not be covered tomorrow or vice versa. This No Pain Act is a temporary.
So, Carolyn, I thought it was very interesting that the patients are going to have a 20% copay for these separately billable agents. With that in thought, we have to make sure that these are always going to provide benefit to our patients if we prescribe them instead of an alternative agent. Phil, this law is intended to encourage the use of non-opioid alternatives by decreasing financial burden. In that statement, I also want to say that we want to make sure that we're being patient-centric and we're helping the patient reduce opioid consumption. Many HOPDs may not have some of these more expensive branded non-opioid medications on formulary because presumably they have determined that perhaps a generic non-opioid is equally as effective and safe. In this situation, if you were to go into one of these health systems and provide some consultation for them, would you recommend adding one of these branded non-opioid agents that is covered underneath the No Pain Act because it is now separately reimbursable?
I'm going to take a slight step back. The intent of this act was to reduce opioid misuse and abuse. When we look at the surgical setting, it's not only about the medications, it's about the entirety of the process, taking the perspective of an early recovery protocol. That means before you even get to the OR, having consultation with the patient so that you understand the patient, their pain tolerance levels, the expectations around pain, their current medications, their history of abuse or misuse of different products, all the way through until the end, until they get discharged. It's much more comprehensive than this small piece. However, we are pharmacists. We tend to look at it more from the drug perspective. And when I look at it from a drug, specifically from the medications or the devices or medications that are being delivered, I always go to the basics. Is it safe? Is it efficacious and more efficacious than other products? And if those two are roughly equal or equivalent, then is it financially sound or operationally feasible? Let's assume that an organization feels that these products versus others that might not be on this list are equivalent in safety and efficacy. So now you're dealing with the operational burden or the financial burden. And I think it's important to look at total financial burden. And total financial burden does not mean, oh, well, I get reimbursed for this and therefore I break even. Maybe I even make a little bit of money. You have to look at, well, what about your non-Medicare patients? What about your inpatients? When we look at Clinical Database Resource Manager over the last 12 months, the proportion of inpatient to outpatient cases who are getting some of these drugs on this list, there's about 50-50. So 50% of those cases are on the outpatient side. You're going to get this proportion of reimbursement for the drug. There's 50% on the inpatient side, zero reimbursement. You're eating that cost. From a total financial perspective, maybe it's not worth it. Maybe it is. It really is up to the organization to decide. From an operational perspective, it's important and incumbent on the organizations to make sure they cross their T's and dot their I's if they try to take this opportunity to enhance their revenues. We've seen during the ASC process where ambulatory surgery centers had access to this reimbursement, a number of programs that we would visit where they actually weren't getting the reimbursement that they thought they had. And it was for a number of procedural reasons. However, those things happen. So it's important that if you choose to go this route, that you would make sure you include the pharmacy team, your physician stakeholders, your finance team, your IT. It is quite an operational undertaking to make sure that you meet these criteria for getting appropriately reimbursed.
Thanks, Phil. You had a lot of very, very important points in that response. Number one, iterating that the use of non-opioids is just one small piece of the puzzle at reducing prescription opioid dependence. It's more than just that one step. The second thing that I thought you said that was very interesting was that this only applies to outpatient and that about 50% of those procedures are still inpatient. And the third was that it only applies to Medicare patients. And obviously we have commercially insured patients that are being treated in these HOPDs as well. So Carolyn, because it only affects reimbursement for Medicare patients, do we ever see commercial payers being influenced by the policies of CMS?
We do. When we talk about reimbursement, we typically talk about CMS reimbursement. CMS sets the stage, and often we do see other payers, private payers or Medicare Advantage plans pay in a similar manner. Doesn't necessarily mean they always will. When you think about private payers and Medicare Advantage, a lot of times those payments are all part of a bigger contract negotiation where CMS will pay very specifically separately for these medications. It depends on what's in those contracts. It's also, we're just a few weeks into January. It's a little too soon to tell.
In 2016, the CDC came out with opioid guidelines and then had to come out with additional guidance in 2022 because oftentimes we saw that patients who were in need of opioids weren't necessarily receiving them. Phil, can you comment on the importance of opioids in pain management?
This is a small piece of the overall pie of trying to reduce opioid use and opioid abuse. We also have to be cognizant of the fact that opioids do have their place. And we don't want to swing the pendulum so far to the other side where now we're avoiding opioids in patients who absolutely need it. And I've seen that happen. I've seen folks who had terrible neuropathic pain and were refused to be given opioids, particularly during the acute event, because they couldn't prove that they had this pain. And physicians became so concerned about opioid misuse that they would just provide the patient with other non-opioid alternatives. At that point, it gets a little bit concerning to me. So I think it's very important to be cognizant of the need for opioids in certain circumstances and to make sure it's just a component of the overall pharmacologic and non-pharmacologic pain management protocols you have.
Carolyn and Phil, thank you so much for joining the Verified RX podcast today to share your insights around the No Pain Act. I know I learned something today, and I'm sure our listeners did too.
And thanks for having us. This is a great topic.
Thanks, Stacy. Please join us for more Verified RX podcasts. Subscribe today. Like us. Send us your comments. We'd love to hear from you. Verified RX is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.